طبعا management of open fracture, we already took a lecture about this and we discussed everything. Like, this is just a quick review on how to manage open fractures practically, especially in the emergency room. This is just a quick review of what we had before. طبعا we're going to talk about clinical case. So this is 22 years old gentleman was involved in a road traffic accident, presented to the emergency room with deformity and wound in the, and start assessing this patient. Assume that you're in the emergency room and the patient is in front of you and you have been called to assess the patient regarding his limb injury.
Doctor, we have to ask about the mechanism first.
طيب, mechanism of injury, very important. What else?
Doctor, I will check ABC first, airway, breathing, and circulation, because he is a road traffic accident. Maybe have another damage anywhere.
It's very important to start with the ATLS protocol, Advanced Trauma Life Support, which starts with the primary survey, A, B, C, D, E. A, airway, B, breathing, C, circulation, D, HD,
Disability.
disability, E, exposure. Exposure and mechanism of injury or environment that he was exposed to. Okay, so this is very important. Any patient who presents to the emergency room with a road traffic accident, you have to consider doing the ATLS protocol. In some cases, especially in the exam or some, questions, when you have a case like this, you have to mention ATLS, and most of the time the examiner will tell you whether the ATLS was done or not. And usually if they want you to focus on the injury itself, they will tell you that ATLS was done and this is an isolated injury. So you can focus more on the injury itself. So if this is a pure ATLS station or case, so once you do the A, B, C, D, E, you have to do the adjunct, which is chest X-ray, pelvic X-ray, and then you do the secondary survey, head-to-toe examination, and also at the end do the tertiary survey. So in this case, this is an isolated injury. So what's the next step?
Doctor, I will start to manage the wound locally. Then I will
Before
give
you go
him,
to the wound,
staging the open fracture.
and before doing this,
secondary
then
survey.
we'll focus on the just for the sake of completion, we'll take it systemic and then we'll focus on the practical part more. So once it's isolated injury, ATLS is done, isolated injury. So how do you start?
Ample for
ample history.
Yes.
طيب, so what about ample history?
A for allergy.
Tell me what's ample history.
A for allergy, doctor. M for medication. B for past medical and past surgical. L for last meal.
Yes.
E for the event.
ممتاز. So this is a focused history in the cases of open fractures where the patient is really in pain. There's not much time to go through classical history style, chief complaint, past medical, social history. So in this case, you need to take, brief history to the point and only take the relevant information. Right, so once you finish the ample history, what do you do next?
You'll start staging for the open fracture.
Okay, before that, just imagine that you have the patient in the emergency room and you're dealing with him step by step.
Okay.
Assessment.
Okay, assessment.
Of the injury and the contaminated.
So you move
injury
on to
also.
the physical examination. Physical examination, you check the vitals, you check the general status of the patient, and then you do local examination of the affected limb. Look, feel, move. So look, you can describe the wound. Feel, usually you don't need to do this because it's obvious that this is, an open wound and there is deformity, so most likely there's a fracture. Move, it's usually not recommended to ask the patient to move his limbs when there is a clear fracture. So this is, physical examination is very limited, especially in open fracture. So mainly it's describing the wound and managing it, plus one very important part, which part is that?
Again, doctor.
So after you describe the wound and you do local management of the wound, there's one important part of the history of the examination that you should
Ask about the place of fracture or
examination.
Yes. On examination.
Hmm.
Look if there is contamination or not.
Neurovascular examination.
On neurovascular compartment.
Is very important. Right. Once you do the neurovascular examination,
Check for sign for compartment.
also you can check for compartment. This is very important. So now we should focus on local wound management. So now you saw the patient, you made sure the ATLS is negative and the patient is stable. This is an isolated injury. You take a quick ample history. You examine the patient. You make sure he's stable, vitally stable. He's not in pain. You describe the wound. Neurovascular, he's intact. And now we want to start taking care of the wound itself. So let's talk about this in a step-by-step fashion. So imagine you have the patient in front of you now.
Okay.
You have a wound, so how would you assess and manage this wound?
First, I will stage the fracture, doctor. Then we'll manage wound locally. Then depend about the stage of fracture will be the management. And then give he tetanus vaccine. Also depend on the case, if he contaminated or not, if he take it before 10 years, if he not contaminated or not. And fix البون اللي هو read if he display sure open fracture displaced, I will make the bone in his normal place and fix it and recheck the neurovascular examination.
طيب ممتاز. So regarding the grading of the fracture, so it's important to have a preliminary grading just for the ease of communication. But the most reliable timing for the grading is in the OR once you debride all the necrotic tissues. But starting with grading will help with communicating with your colleagues. So say if you wanna relay this history to your senior, you can say this is a grade 1, 2, 3. Then that will give him an idea, and then he can imagine the picture of the wound. Then starting with local assessment. So it's very important before you start with the local wound assessment or care. You have to make sure the patient received the required medications. What are the required medications? So we talked about tetanus. You have to check tetanus status. What else?
Give الانتيبيوتيك all open fracture will give him 2 antibiotic يا دكتور ثابتين اللي هم سيفترايكزون مع اللي هو شو اسمه جنتامايسين، واذا كان contaminated او third degree بضيف لهم انتيبيوتيك ثالث اللي هو اموكسيسيلين او امبيسيلين.
ممتاز. Okay, so also grading is very important to decide which antibiotic should give. So grade 1, you can give third generation cephalosporin, is enough. If it's grade 2, you can add aminoglycosides, اللي هي gentamicin. And if it's grade 3 or soil contamination, then you can add penicillin. So this is also important. So antibiotics, this is the most important thing. The moment you receive the call, first question to ask, did you give the patient antibiotics? Because that's the most important factor to reduce risk of infection in patients with open fractures. You can delay his surgery 24 hours or to the next morning, that's fine. But delaying administration of antibiotics will have significant impact on the patient's outcome. So antibiotics, number 1. Number 2, tetanus status. And then the most important thing that the patient will ask about is usually pain medications. So make sure before you start assessing any patient that you have mentioned that, or you have made sure that he received 3 medications: antibiotics, tetanus vaccine, and the last thing is, or the most important thing is
analgesic.
Okay, so now start with the local care. So you have to explain to the patient what you're going to do. So you tell them that you have, this wound, most likely you're having an open fracture. We need to clean the wound, and then the next step will be getting x-rays and then, proceeding with the rest of the management. Very important to use the standard biohazard precautions to protect yourself: gown, shoe cover, sterile gloves, and then obtain informed consent. Most of the time it's verbal, but in some places you can, or you should make the patient sign a paper. But informed consent is not necessarily a paper, sometimes can be just verbal. The medications should be put in mind: antibiotics, analgesia, and tetanus precautions, or tetanus toxoid. So do you remember what is the algorithm to give the tetanus toxoid or immunoglobulins?
Doctor, if he is contaminated and he don't know if he take the tetanus vaccine or not before, or he doesn't take it.
So you should and make sure whether this is a clean wound or other wound, because you have to classify the wound. Clean wound, what are the features of a clean wound?
Doctor, if clean wound, I will ask if he take it before 10 years or not. If before 10 years, I will give him the vaccine. If he during the last 10 years, I will do nothing.
So there is 3 questions to ask. First question to ask yourself, what type of wound is this? Clean or other? Okay. If it's clean, it has a path. If it's others, it has a different path. In this case. So the second question you ask yourself, what's his tetanus vaccination status? Up to date or unknown or incomplete? If it's up to date and the wound is clean, and then you ask the third question, when was the booster given? The boost dose, when was it given? If it was given within 10 years, and the patient vaccination status is up to date and the wound is clean, you give nothing. If it was given more than 10 years, then you give Tixoid. Okay, so another scenario, if you ask yourself what kind of wound is this, and this is a dirty wound, and then you ask yourself what's the vaccination status, up to date or unknown or incomplete. If it's incomplete or unknown, you should ask when was the booster. If it was the booster dose less than 5 years, you should give Toxoid. If it's more than 5 years, you give Toxoid and immunoglobulins. So the main thing is the timing of the booster dose. If it's a dirty wound, it's usually 5 years time frame. In a clean wound, it can be up to 10 years time frame. So you should go back to the table in the lecture and memorize, but always remember that there's 3 questions to be asked. First question, what type of wound is this? Second question, what's the tetanus vaccination status? And third question is, when was the booster given, if any? Now that we made sure that the patient received all the required medication, consent was obtained, you're wearing the universal precautions, and then you start managing the wound. Expose the wound and obtain a photo if possible. Why is that? Because if you want to show the wound someone from the team, you don't need to re-expose the wound and show him. You just show him a picture and the picture will tell a lot. Remove any obvious foreign bodies from the wound. Avoid digging deep into the wound. Anything superficial you should remove. Irrigate the wound with normal saline, 1 to 2 liters. Make sure the normal saline is warm enough. And make sure the patient has received adequate analgesia, because when the fluid comes on the tissues, they might cause some pain. Push any prominent fracture fragments gently back in place. If you see any loose piece, you should remove it, except in one case. When is that?
دكتور معلش الصوت قطع. وش
In which case you should keep the bone even if it's detached from any soft tissue.
إذا كان في الجوينت from the joint.
If it's part of the joint, there's articular particular cartilage attached to it, so you should keep it.
Yes.
And then at the end, cover the wound with a sterile gauze, wrap the limb in a sterile cotton. If there is any active bleeding, you should make sure you apply pressure till the bleeding stops. And then after you finish all this, what shall you do? So you finished local wound, you did the neurovascular examination before, and then you should do it after. And then what do you do? ما في
reduction.
إذا واحد أو اثنين يشاركون، أنا أول مجموعة تشارك ولا نايمين؟
دكتور reduction البون بعد
موجودين يا
بعدين.
دكتور.
طيب وين المشاركات؟
أنا الثاني اللي أشارك معك.
وين الثالث وين الرابع؟
موجودين يا دكتور، تفضل.
موجودين يا دكتور أسامة، موجودين.
احنا عارف انكم موجودين بس واحد يشارك. طيب. So you check neurovascular examination, you realign the limb, reduce it, put a splint. Again, recheck the neurovascular examination, send the patient for x-rays, and then book the patient for surgery for adequate debridement. So this is the open fracture management part. في section عن history taking في infection. So this will be talking and discussing some cases, no slides. When you have patients, I'll give you one slide. I want everyone to participate. If you have a patient who's 4 years old, brought by the mother to your office because he started limping. So how would you start history taking for this patient?
I will ask about the onset and past infection or trauma or
if he painful or painless.
Doctor,
Okay.
first of all, I check the patient personal data and how he get the infection. Has he had any continuation wounds before, or traveling, or something where he lives, if he lives on farm or somewhere which have more bacterial or viruses.
طيب أنتم كم عددكم؟ كم عدد المجموعة؟
دكتور عدد حضور
لا، عدد المجموعة كم؟
47.
ليش نصها غايب؟ المرة هذه والمرة الماضية. المرة الماضية قلنا اختبار مو مشكلة، بس اليوم ليش النص غايب؟ في أحد يسجل الحضور؟
ايه يا
في
دكتور
برنامج
يتسجل
يا دكتور
على موديل.
كيف طريقة برنامج موديل هذا؟
التحضير يكون اونلاين يا دكتور على الموقع حق الكلية.
كيف طيب؟ ايش طريقته؟
يفتح على وقت الساعة 8 ويقفل 9.
يعني أنا أحضر على موديل وأنام عادي.
بعدين الدكتورة تقارب بين حضور زوم وموديل.
إيه، من ياخذ حضور زوم؟
صراحة ما ندري يا دكتور، بس المفروض ان الدكتورة تاخذه.
أحيانا تكون موجودة الدكتورة في المحاضرة فتاخذ الحضور.
او تكلمني انا اخذه يا دكتور، اخذ سكرين شوت للبارتيسيبنتس وارسله لها.
والله شكله من الحضور عندكم إنه ما فيه، ما حد مهتم بالموضوع. طيب عموما أنتم جروب ضعيف جدا يعني للأسف. طيب. You should ask first, what's the history of chief complaint for this patient? Is it limping? Is it pain? Is it swelling? So once you know what's the chief complaint, then you focus on it. So if he's limping, then you ask, when did he start limping? Was that sudden or gradual? Any associated trauma? Any other associated symptoms other than limping? And then limping, as we mentioned, sometimes can be due to pain, sometimes can be due to other things. So if the limping started suddenly and is due to pain, then you focus on pain history. Sometimes from the beginning, you can ask the patient why you're limping, he'll tell you because of pain, and then you focus on pain history from the beginning. And you ask all the pain history questions. And then we go back to the etiologies of pain in any joint or complaint of any joint. And then you ask yourself, is this due to trauma? Is this due to infection? Is this due to tumor or inflammatory process like juvenile rheumatoid arthritis or any other kind of connective tissue disease or inflammatory process? Should ask yourself, is this congenital? The patient is 4 years old. So you ask, when did this start? So they might tell you this started since birth. What else? What else we missed or did not mention
here? Because he is child, doctor, I will ask about the يعني قبل الولادة في شيء أثناء الحمل during pregnancy أو
طيب asking about etiologies. وش الetiologies؟ هل في شيء ما ذكرناه؟ trauma, tumor, infection, inflammatory, degenerative, this likely in pediatrics.
الديابيتس دكتور غالبا يكون او بعض الاحيان اذا كان اجريسيف وان كنترول وكذا وستارت تو هذا يكون في انفكشن في البومبات.
انا اتكلم عن الايتيولوجيز. الايتيولوجيز هذه في كل
كيف
محاضره
طريقة؟
اذكر لكم اياها، كل محاضره نعيدها. طيب ما مشكله.
دكتور الاتيولوجي اوف limping.
Etiology of any MSK complaint.
طيب trauma, infection, congenital malformation,
طب أنا أقول لكم إحنا ذكرنا مجموعة، قلت في شيء إكسترا ما ذكرناه، بس هذا سؤال yes or no.
painful أو
تقريبا ذكرناها كلها.
طيب. So this, back to this case of 4 years old limping, then you start asking all the pain questions. When did this start? وش البين questions؟ اذكروا لي إياها.
Site,
severity
onset, duration, radiation,
Site, onset, duration, radiation.
severity
aggravating factor, relieving factor.
association
the duration دكتور اللي هو
severity
أو timing إيه والseverity. تسوي stiffness ولا لا؟
طيب
وكم مدة
severity
الstiffness morning stiffness وكم مدتها عشان نفرق بين الانفلاميشن والميكانيكال.
continuous or no
severity of the pain, character of the pain, radiation, aggravating, relieving factors, and associated symptoms. Associated symptoms ممكن تسأل about مثلا swelling, fever.
continuous or no
ممتاز. And then going back to the etiologies, so trauma, how do you rule out trauma?
how he have a trauma by what
How did it happen? The mechanism of the trauma, it's known. How did it happen and when?
Timing less or more than 6 hours.
طيب أنا يعني خلينا نرجع للمنطق. جيتك أنت ما أنت الطبيب وأنا ماني بطبيب، إحنا زملاء في كذا في الاستراحة جالسين. جيتك وقلت لك أنا أحس إن عندي عرجة، تيجي تسألني على طول كيف صار الحادث؟
وين
من متى لاحظتها؟
متى بدأت دكتور؟
متى بدأت أو متى لاحظتها؟
You ask if there is any history of trauma. You don't ask how did the trauma happen. يعني كمان يا شباب يعني common sense. You want to rule out trauma, you ask any history of trauma. He presented to you limping. هو ما جاك في الإسعاف وصار له حادث. Trauma, you ask about any history of trauma. أمه بتقول لك ما حصل trauma. There's no history of trauma. Then trauma and fractures is ruled out.
بسأل عن sign and symptom of infection, erythema, discharge from the site of pain.
Maybe swelling also دكتور.
Swelling, yes.
طيب يعني something even more important, history of fever, contact with
Fever,
sick
night
patients,
sweat,
previous history of infection, upper respiratory tract infection, constitutional symptoms مثل night sweating و loss of appetite, weight loss، الشغلات هذه، pain at rest، هذه كلها تدل على وجود infection.
especially TB infection, doctor, for respiratory. If I ask about, especially for TB.
طيب TB, you ask about respiratory symptoms, history of contact with TB patient, or history of travel, very important. So these are important questions. Inflammatory, ممكن you ask about history of stiffness, other joint involvement, when did this happen, gradual or sudden. Inflammatory disease doesn't happen suddenly. So it happens gradually, involve more than one joint. There's usually no fever, there is associated stiffness with it. Tumor, history of tumor, we ask about, this less likely in this case because he's limping and he's having pain. But tumor, we ask about constitutional symptoms, pain at rest, زين. It can go also with tumor, like this can be ruled out later on physical examination and imaging. Congenital, you ask, when did this start? So if this started only a week ago or a few days ago, and since birth he was fine, so usually this is not congenital. Asking about, perinatal history is very important. Asking about vaccination status, if it's up to date or not, it's very important. Like, the main idea I want you to get is, when you have a patient who's complaining of something, you have to think about these categories, these boxes, rule out each one, and then you'll have a limited, differential diagnosis. Right. So 4 years old, limping started yesterday. It started suddenly. No history of trauma. He had upper respiratory tract infection 2 weeks ago. Treated at home with only Panadol and some home remedies. And after that, he woke up yesterday and he was limping and complaining of pain in his groin.
دكتور هذا غالبا septic arthritis في الهيب hip joint.
So septic arthritis is also, it's the top of the differential diagnosis. What else?
Osteomyelitis.
Osteomyelitis.
So usually infection, this can be acute or chronic.
Yes.
Infection can be in the joint or in the bone. In the joint is septic arthritis, in the bone is osteomyelitis. Presentation in an acute infection is usually similar in both septic arthritis and osteomyelitis, especially when you talk about history. But when you go to examination, the main difference between them, septic arthritis, you'll have significant limitation in motion in the joint. Patient will not allow you to move the limb, while in osteomyelitis, the joint movement is fine, but the patient is having pain around the joint. So for your differential diagnosis, septic arthritis, acute osteomyelitis, always infection, always tumor goes with infection, but it should be on the bottom of the list. So this is your differential diagnosis for a patient with limping and who's around 4 years old. What else can be the cause of his groin?
معلش دكتور تعيد السؤال.
ليش يقطع يعني ولا؟
النت عندي أنا ما سامع كويس، ما أدري عن الشباب بس أنا
هو
ما سامع.
يا دكتور قطع في نص السؤال.
What else can be a differential diagnosis?
tuberculosis.
ممكن bone tumor يعني بس.
The camera tumor, TB can be also, لكن
Yes.
less likely.
Rarely.
No
Yes.
respiratory symptoms, just happened acutely. No contact with TB patients or no history of travel. Transient synovitis. سمعتوا بالترانزيت synovitis?
Yes, inflammation synovial fluid.
So inflammation of synovial fluid can represent just like septic arthritis. So how do you differentiate between transient synovitis and septic arthritis.
Aspiration.
infection. Respiratory
إيش؟
infection. كم
كان
after
قاسي.
respiratory infection or any other joint infection.
لا. So
And time.
transit synovitis, from its name, it's transit. So it will respond very fast for non-steroidal anti-inflammatory medications. So you give the patient Profen and monitor him for 24 hours, he will improve. Okay. But how would you investigate this patient? So you suspect septic arthritis versus transit synovitis.
By the lab.
Okay, so what kind of labs will do?
CBC.
أيوة.
C-reactive protein.
C-reactive protein, دكتور. C-reactive protein, CRP.
CRP وش
جرام نيجاتيف.
نسوي MRI depend on the X-ray and the CT if needed or not.
guided aspiration.
ultrasound دكتور guided aspiration عشان أشوف.
طيب أنا بقول لك شيء. أنتم ما عندكم، ما في حد منكم عنده طفل؟ في حد منكم متزوج عنده أطفال؟
من ناحيتي لا.
عندك إخوان صغار؟
لا أنا
إيه
لا.
دكتور.
طيب أنت اللي عندك أخوك الصغير أخذت على الإسعاف وشافه واحد انترن ولا واحد ستودنت ولا واحد ريزيدنت، وأول ما شافه قال أنا I will do aspiration of the joint. تخليه يسوي الاسبيريشن؟
No, first blood investigation.
لا طبعا يا دكتور.
أول شيء يسويه لا يا دكتور.
Non-invasive.
How to convince me to do aspiration. أنا أبو المريض and this is my son.
بعد ما أسوي minimal invasive investigation.
وش minimal investigation؟
اللي هو CBC C-reactive protein، بعدين أسوي ultrasound.
ممتاز. ultrasound. So you have to confirm that there is fluids to be aspirated. ما هو بس تجي تقول لي I will aspirate the joint. Aspirate what؟ تحط النيدل تلقاها dry tap. Doesn't make sense. So you have to be systemic. Blood tests, simple X-rays. If you expect to have fluids, like in the case of septic arthritis, you do ultrasound. You assess the ultrasound, see if there is fluids or not. If there is high suspicion of septic arthritis, once you do the ultrasound, you can ask the radiologist to do, aspiration, to take some fluids and send them. But you should not answer, randomly. Always imagine that you are the patient. See what makes sense to you before you say it. Right, so this is a scenario of acute infection, mainly septic arthritis. But what are the complications of septic arthritis? It's if left untreated.
Osteomyelitis, sepsis.
Osteomyelitis, sepsis, what else?
Septic shock, doctor, because the sepsis, organ failure, multi-organ failure.
طيب, what else?
Myocarditis.
Surgical fracture.
Necrosis.
Necrosis of what?
Of bone and tissue.
Which tissues?
Cartilage and surrounding tissue.
إيش؟
في الجوينت قصدك يا دكتور؟
إيه.
The infected bone.
joint destruction,
Joint destruction, cartilage will be destroyed, so that will lead to premature arthritis. Also, this can lead to osteomyelitis. Osteomyelitis can be chronic, so this can lead to chronic osteomyelitis. Let's give you another scenario. So this is 40 years old, presented to your office complaining of thigh pain. Thigh pain was there for about 2 years, and it's getting worse. And now he's feeling pain and swelling in the thigh. And who would like to take history from this patient?
دكتور هو غالبا انفكشن، بس ببدأ بنفس الأسئلة، أسأل عن التروما بعدين الانفكشن بعدين نفس الأسئلة اللي سألناها في الكيس اللي قبل.
What's
بعدين
his chief complaint? بيدخل عليك مريض يقول دكتور أنا راسي يوجعني، رقبتي ترجعني، إصبعي يوجعني.
اوكي
الشيف كومبلين
تهاوش من حق الاستقبال.
الشيف كومبلين هو الألم اللي في الفخذ اللي معه من سنتين للحين.
تمسك المريض قل له okay, I know that you have a lot of problems. Tell me what's your chief complaint. We need to focus here.
اللي هي ألم في الفخذ اللي قلت أنت دكتور اللي بادي معاه من سنتين and gets worse and until now.
Thigh pain. خلاص. Focus on thigh pain history.
complain, and
What are the questions you ask?
after that I will take details for chief complaint, when, where, elevating,
relieving factors. How does it start? كيف بدأ معك أصلا؟ في history of trauma, في history of inflammations, respiratory diseases. We ask these questions.
Pain questions you ask, and then you ask about associated symptoms.
About fever or local fever, local hyperthermia. يعني تكون مثلا مكان الألم فيه حرارة أو شيء.
What else?
في tenderness ولا بس pain؟ يعني he feel pain but if he touch it no tenderness. There is tenderness or not. صعوبة بالمشي، صعوبة مع الحركة، بالألم ثاني. هل في يجيك في وقت معين أو لا؟ يعني مثلا يكون فقط في الصباح أو وقت الليل في المساء أو كذا يعني.
So this patient, he said he's 40 years old. He started having pain about a year ago. Pain, swelling of the thigh, but it subsides and then comes back. So now he's having pain for the last month, not getting better. Pain, as we mentioned, started a year ago, gradual. It's continuous, most of the time at rest. Aggravated by, walking, and only alleviated by pain medications, associated with swelling, and sometimes you feel, hotness in the area. What else you want to ask?
Doctor, I will ask about the radiation. Is it radiate inferior to the knee or only localized to the thigh?
It's localized to the thigh.
Stability.
Stability of what?
range of motion.
You ask a patient stability of the range of motion in history.
if he walking or have a problem or no.
Doctor, I ask about history of trauma, if he has a trauma before in the same area or not.
ممتاز. So you ask about history of trauma. He tells you 2 years ago, I had an accident. And then I had a fracture on my femur and I went to the hospital and I had surgery. Huh.
After the surgery, the post-operation, has he had the antibiotic course or not? So ask about the antibiotic uses. Sometimes they get infection of post-surgery.
So you asked the patient, he said, I had surgery, and then since surgery, things were fine, but I was having some discharge from the wound, and the doctor gave me some antibiotics.
أسأل عن الكورس حق الانتيبيوتكس. Has he finished it or just stop it where he يعني بعد ما حس he's relieved يعني. Have he had any analysis for this septic before? Yeah, for the discharge before or not also?
And so they gave him, they told him this is, superficial infection. And they gave him antibiotic course for 2 weeks. Things has improved, but since, the last course, every 3-4 months, he will have some discharge coming from a small opening in the previous wound. And it will take, a week and 2, and he will go to the pharmacy, take the same antibiotics, and then it will close by itself. So what do you think the diagnosis is? What do you think is the, list of differential diagnosis?
Totally clear septic arthritis, but
what?
Totally clear septic arthritis.
Septic arthritis of what?
ذهب استيميلايتس دكتور في الثاي.
استيميلايتس تكون كومبليكيشن للسبتك يا ولا
كرونيك استيميلايتس.
طيب شكلك ما ركزت في المحاضرة اللي تقول septic arthritis can be only complication. Septic arthritis can cause osteomyelitis. Like osteomyelitis can come immediately from previous surgery, direct invasion of bacteria to the bone, or bacteria can be transmitted through the blood from any source of infection in the body, throat, ear, bladder, can cause osteomyelitis. So this case indicates, chronic situation. Patient has been having on and off pain and swelling in the thigh for 2 years. In the history, there was significant, piece of information, which is surgery for a femur fracture. So you should ask, where did you get your surgery done? What exactly was done? Was it an open fracture or not? Okay. and any complications after the surgery. They might tell you that it was an open fracture, and then I had some infection after the surgery in the wound. Presence of a sinus usually indicates chronicity of the infection. Usually chronic osteomyelitis will be fluctuating in presentation. Sometimes can be silent and then flare up and then go back to to a state where it's not bothering the patient and then flare up again. And in this case, so the patient had surgery. There was some active discharge after surgery. He received antibiotics in the past. History of multiple antibiotics regimens throughout the year. So you think more about chronic osteomyelitis because of the surgery. Chronic osteomyelitis also can happen in a patient who had acute osteomyelitis in the past. This can be a 10 years old girl with a history of acute osteomyelitis about 1 or 2 years ago, treated with a course of antibiotics, debridement of the bone, etc. So this is how you should obtain a history for a patient with chronic infection. So you ask about pain history, any presence of sinus, for how long this has been draining, any treatments before, what was the trigger of this, any previous osteomyelitis, any previous septic arthritis, any previous wounds in the area that was infected and neglected, any previous surgeries. Most of the time, patients who come with chronic osteomyelitis, 99% of the time, they have previous events related to this, and you cannot, or they cannot forget it. Trauma, fracture, surgery, major infection, major wound. Then, so all these are very important. And then once you, so past medical, past surgical is very important in general, especially in case of infection. Why? Because sometimes you can ask the patient with past medical history, he'll tell you he's diabetic, he's on immunosuppressive medications, he's known to have rheumatoid. He'll tell you that he's having compromise in his immune system. So this is also very relevant and important. What else can be relevant and important in past medical and surgical history and social history? So past surgical history, we mentioned history of fracture and fracture fixation was very significant in this case. Past medical history is diabetic, uncontrolled diabetes, so this is important for the for his immunity. Smoking and social history, so the patient is smoking and he's not compliant and he did not stop smoking. This can be also cause of his recurrent infections and can cause him chronic osteomyelitis.
As you mentioned before, Dr. Respiratory infection as Staph aureus, Salmonella, TB for osteomyelitis برضو previously infection يعني.
ممتاز.
previous surgery.
كيف؟
previous surgery or
اي قلنا previous surgery. ما كنت مركز. طيب في أي سؤال clear to you how to obtain history, how to navigate through history and make sure you rule out any of these major etiologies and then focus on the right etiology and narrow differential diagnosis. You should always follow system and then narrow differential diagnosis, and then the more information you get, the narrow differential diagnosis, and then confirmation of diagnosis will be either by clinical examination or imaging. في سؤال شباب؟
الله يعطيك العافية دكتور.
بالعافية يا دكتور، ما قصرت.
الله يعافيكم. يلا مع السلامة.
يا هلا، حياك الله.